The reason is we have the opportunity to help people that can't afford to do a more expensive solution to replacing their denture or stabilizing their denture. Some of the people don't have enough bone, aren't looking for the bone grafting and the kind of expense and time that it takes. And other the people just aren't healthy enough to go through the kind of surgery it takes to do root form implants. So I have a solution for them that's at the bottom of the affordability scale. There's nobody walks out of my office that doesn't have a procedure to help them stabilize their denture that they can afford. We can actually finance this with for somewhere around $95 a month. Even the people on Social Security can afford to do 4 mini implants to anchor down a lower denture. I understand that, and part of it comes because originally they were designed, or at least people think they were designed as transitional implants, but they do integrate. And a lot of the dentists that are out saying they don't work didn't come to a course and learn what the protocol is. And one of the big problems that we have is they're going to drill an osteotomy instead of a pilot hole. An osteotomy is to full length. That's not the way it works. You'll have a high failure rate if you do that. We do a little pilot hole, and the implant is self-advancing down into the bone, lots of initial stability, and those will integrate and work. If you're going to drill the entire length, not pay attention to the protocol, even the prosthetic protocol is important, then you're going to have a high failure rate, and people are going out and saying these things don't work. Well, guess what? If all of us that are getting these things to work at 90 plus, most of it 97% success rate, and you aren't getting success, it's probably not the implant. He's a big fan of what he calls small diameter implants because there are a lot of people that don't have enough bone and a lot of people that don't have enough money to be served by the root form implants. And he's of the opinion that every general practitioner should do mini implants. They teach them at UOP to the pre-doctoral dental students. They get to do those cases when they're still in dental school. They're not difficult. Everybody already has the skills. Anybody that's drilled a post hole into an endodontically treated tooth has the skill to do it. And it's just a matter of learning case selection, case planning, and learning the protocols. If you follow the protocol, it's quite easy. Every dentist has enough knowledge and enough skill to do it if they just study a little bit.
I know at the start of the course it was discussed how easy it was, and I think you're actually going to walk through it while I do it here in just a moment.
Sure, that'll be great fun.
Okay, all right, so give us just a second, we're going to set up.
We've already marked the spots on the plastic tissue here of about 5 millimeters from the midline and about 15 millimeters from the midline, which is where we want the two to go. Let's take a careful look at the angle of the mandible because it's not straight up and down, so it's going to have to be going in at an angle in that direction so that you aren't going out into the lingual fossa down there.
Okay.
Okay?
All right.
So let's try it. The other thing that we're going to want to do, because the object here is just to puncture the cortical plate. If you put that drill on it, stand on it, and push, when it gets through the cortical plate, it will advance a long ways before you can stop it. So you want to do this with gentle pressure, a little bit of pressure on and off, not raising the drill off of the bone, but just kind of pressure off, pressure off, pressure and off, pressure and off. And then when it goes through, you won't advance it that much farther, and we'll have way more initial stability.
Okay, we'll do this.
Very, very good on the angle too, by the way.
Thank you.
Light, gentle pressure. Light pressure. There you go. Much better that time.
Okay.
Do you see the difference?
Absolutely.
Okay.
Yeah, you can feel it give way. Okay, so we've got our, and this is how the mini dental implant comes.
Yes.
Right? Okay. So we'll put it, get it out of the casing here. Put it in. Give it a couple of screws to.
Let's do this with the mandible.
Okay.
Do this.
Good idea.
So that you can.
Give it a couple of screws to get it going.
That's probably plenty.
Okay, just pop it off. And then I know there's different tools, obviously, that you use.
That's the finger driver.
Okay.
Make sure it's completely seated onto the implant before you start to twist it.
Okay.
Which it is.
Okay.
You want to twist it as quickly as you want to go.
Okay.
And it's going to get too difficult, and you're going to need a little bit more torque than your fingers can put on it, and then you'll switch to the thumb wrench, which is this one. And this is one you have to be very careful. You get on all the way visually. You hear it, see it, and then you know that you can begin to use the tool.
Okay. And when do I know, or when would anybody know how far is far enough to have the implant down?
Well, we're going to want all of the we're going to want all of the blasted threads in the bone.
Okay.
And you know that tissue is about 2 millimeters thick, and you've got about 2 millimeters worth of smooth threads that aren't blasted.
Okay. So
it's not down quite far enough, and let me show you why.
Okay, sure.
Let's go put the housing on it.
Absolutely.
And you see there's a great deal of space between the housing and the implant. It actually creates more forces the higher up that it is. If you get it too far in, then the housing itself will rub on the tissue and cause a sore spot, and you can't adjust the housing. You're then adjusting tissue, which the patients don't like. So you don't want to go too far either, but it needs to go down another 2 millimeters or so. Why don't we switch to the torque wrench here?
Okay, you do that.
And I'm going to suggest when you do this that you put your fingers on the lower border of the mandible and put the thumb on the top of the torque wrench.
Oh, okay. So something
Like
this?
that. And I want you to use this thumb on the top of that.
Okay.
Make sure that this is the instrument that's far easier to break an implant with, and we're going to go 7 seconds for each quarter turn there.
Okay.
It's a little bit on the fast side. Now, actually, this patient probably won't overheat and won't mind. So for demonstration purposes, you can go a little faster than that.
But 7 seconds.
But I want 7 seconds per quarter turn here in order not to overheat the bone.
6, 7. I think you said earlier you actually had the dental assistant count.
I have my assistant count because I can't. My 7 seconds is only about 3.
And I can see how that's very possible. Okay. 3, 4, 5, 6. How do you think we're looking?
You still have a ways to go. Let's put the housing back on and look to see where we are. We still have a bit of a space, so we still got some to go. Probably at least another millimeter. We're going to only want about 1 millimeter to 1.25 millimeters of that square showing above the tissue.
Okay.
As you saw that drop all the way to place, and you heard it drop to place.
I did, absolutely.
The object here is to make sure that you don't get that out of perpendicular, because that's how you break an implant. When they come off a little bit and tip, your left thumb there is keeping downwards pressure to make sure that the instrument can't come off of the implant.
Gotcha.
And then I've never broken one by following this protocol. I've heard of people breaking them, but I've never broken one, and it's partly just don't force it, take your time, and make sure it's perpendicular.
This is a very patient process, at least at this point.
Yes. Even still, it probably is only going to have taken about 3 minutes to 4 minutes to do each one of them. It's not very long.
How many of these would you say you've done?
Oh, I don't know.
You can guess?
I don't know, 300, 400. I really don't. I think Imtech probably has an idea of how many I bought, but I don't really know.
Okay. Let's see how we're doing here.
Now we're getting down to the point of we're almost a little bit too far.
Okay.
And we'll look at that and see, oh, it's just about exactly right.
There you go.
Just about exactly right.
All right.
I'd like a little more margin for error because as the denture collapses onto that, you can see the implant moves here.
Right.
It moves apically when it gets pushed on. So there's actually space on top of the implant where it's not touching the underside of the housing to give some give so that the tissue will take the load, the occlusal loads first, and it doesn't touch the implant until the tissue is collapsed by probably on the order of 1 millimeter, millimeter and a half. It's much safer to keep the implant from actually supporting the occlusion. The implants are designed to retain the denture, not support the denture. We're trying to keep the support on the tissue itself. The retention is coming from the implant. That's very nicely done, Kevin.
Okay, well, thank you. Hey, I've got one in the book, so a few less than Dr. Sawyer. So, Dr. Sawyer, thanks for your time. I really appreciate it.
Thanks, Kevin.